So he will be talking on post-refractive surgery IOL power calculation. Over to you, sir.
Good morning. Thank you for letting me go first. I'll start with the story of my patient Sarita Nair, who underwent LASIK several years ago for 8 diopter myopia and posted for cataract surgery. See, we carefully gathered together all the history of information needed and measured the central corneal power using a topographer. The measured and historical data lined up, and we were confident that our estimation of central corneal power is as accurate as possible. Used a SRK by T formula and calculated the IOL power. Axial length was obtained using the optical biometer. Absolutely no issues with the surgery, IOL in the bag. But on the first postoperative week, she had a refractive error of 2 diopters. So we went back, recalculated everything, confirmed the axial length, and still arrived at the same IOL power. So what happened? So the flattened central cornea not only renders the keratometry inaccurate, but also causes problems with many IOL power calculations, which have been our friends for long. So the third generation 2-variable formulas, such as SRK by T, assume that the anterior and posterior segments of the eye are mostly proportional and use a combination of axial length and keratometric corneal power to estimate the postoperative location of the intraocular lens or the effective lens position. If the central corneal power is low, as we see following refractive surgery, the formula assumes that the anterior chamber is shallow. So why is ELP important? In a 2-lens system, such as we have the cornea and lens there, the power of intraocular lens can be thought of something as a relative figure. For example, you have calculated 21 diopter powers, so if it is in the back, so it is in metropia. If it is 0.5 millimeter posteriorly displaced, the effective power is 20 diopters. If it moves forward, it is 22 diopters. So with a low central corneal power, the formula makes the assumption that IOL that is placed following cataract surgery is ending up sitting closer to the cornea than normal and calls for a lesser power. So that is what happened here. So the flatter the cornea, the bigger the problem. So in what position the IOL calculation thinks that the lens will sit inside the eye can have a profound effect on the IOL power that it recommends. So unless a correction is made for the situation, the centrally flattened corneas will have formulas incorrectly assume a falsely shallow postoperative effective lens position. So the end result is that if you don't make any correction, these formulas following refractive surgery will recommend an IOL power which is lesser than what is actually required. So what do we do? So you can use the double K correction method, which is not done now, but just for the completion and just to see the thought process, I'll just mention it, or you go for the newer generation IOL formulas. In double K correction method, what is done is use the pre-refractive K value for the ELP and the post-refractive K value for the IOL power calculation. So this is the table. So you go through each row here. So for Sarita Nair, it was 8 diopters. Okay, now the axial length was 22. So if the IOL power that was given was 12, we should have put a 15 diopter. So, and for hyperopic, you reduce it. So there are different algorithms and different formula for this tricky situation. But what is mostly followed is to go to the ASCRS website and use the calculation, free calculation available there. So coming back to some more theories, you can have biometry errors and ELP estimation errors. So the conventional keratometers measure the anterior surface with a refractive index of 1.3375. So extrapolation to the posterior surface with a fixed Gould-Strand ratio 1.13. Post-LASIK, the Gould-Strand ratio is reduced with an overestimation of keratometric power. And post-LASIK, in the central zone, there is a wide range of curvature. So when the measurement is done at 3.2 millimeter, it might miss the central flat zone, overestimate the IOL power, and hyperopic shift. So what do we do to overcome these problems? Go for a total K for a calculation that you get for optical biometer like IOL Master 700, or use a pentacam. It gives a, so this is optical biometer. So if it is a pentacam, it has got a holiday EK port, and when you go for that, it gives the equivalent. So that can be used for IOL power calculation. So the newer generation formula include holiday 2, Barrett 2K, universal 2 extra. So when you ask the surgeons, prolific surgeons who are doing a lot of cataract surgeries, post-refractive surgery, many actually use the TK from IOL Master or Pentacam and do the IOL power calculation, and they're getting pretty accurate results. So, and all these studies have shown that it works. The other way which majority uses is to go for the online calculators. Among these online calculators, as I said, the ASCRS is the one that is commonly used. So this is it. So in that, you go to the this site, click on this, and it asks you to enter the data, everything, K, axial length, AC depth, everything, and gives the IOL power that is required. So I prefer monofocals in these cases, but if the patient is really insistent on multifocals, then you have to be even more certain that the power calculation is okay. So this phakic refraction is a great way to confirm the IOL power. So what we do is, the refraction is done immediately after cataract surgery. The cornea has to be wet. Visco has to be totally removed. AC found with the BSS, but not very tight that it becomes, the cornea bulges up, and do the refraction. And the phakic correction is multiplied by a factor of 1.8. And after the IOL implantation also, you can actually reconfirm the IOL power. So which IOL, as I said, prefer monofocals. But if it is a multifocal that is chosen, if the cornea is regular and there are no higher order aberrations, the first choice I would give is the enhanced monofocals like iHands. For multifocals, I go for EDOF like Vivity. So I avoid these in higher amounts of induced aberrations, decent aberrations, astigmatism more than 0.5. Dry eye. Yes, if it is a hydrophobic IOL, I would prefer to go for 0.5 diopters overcorrection. So, because if there is any surprise, it is better, it's easier to correct. So to conclude, it's an evolving field with a lot of recent developments. We have almost reached the accuracy that we achieve with the virgin eyes. The expectations have to be set at an appropriate level. You under-promise and over-deliver. Always plan for managing post-surgical IOL surprises. Thank you.